Hello.
Hello. Hi, John.
Hi, how are you?
Good. How are you doing?
All right, thanks.
Good. I was just getting the last of my pieces of presentation available.
Very good.
Is this the first time ACPE has ever done anything like this?
No, we've done webinars before.
Okay.
Yeah, we actually definitely the last two, maybe 3 years, we've hosted all of Transform Chaplaincy for them. So
Okay.
just like we're doing for y'all, we managed all the registration into the platform. We provide the tech support. On those webinars, we never did any of the curating, but Dawn's saying she needs to change computers. Okay. But yeah, so we've done these webinars before.
Okay.
And then we've also obviously used this platform for our town halls, similar to what you did.
Yeah. So we used GoToMeeting.
Oh, how did that work?
I hate that platform. It's so unstable.
Yeah.
Like really. Yeah. So, and that's my biggest anxiety is having something come up and you're in the middle of this and it bumps you.
Right.
Sorry. Oh, is that Dawn? I need to change computers. Okay, good. So let's just review. So the chat, you're going to manage the chat.
So
that's one of the ways.
Yes. So there's two ways for participants to message us.
Good. Okay.
If you bring your mouse to the bottom of the screen, you'll see the chat, and that's where Dawn messaged us. And so we can have private conversations here among currently the chat that where she sent it to it says all panelists. So that's only for the three of us.
Good. Perfect.
I can switch it to attendees.
No.
And then right, they have to raise and lower their hand and they can put messages here.
Okay.
I prefer that they don't use this. What I prefer is the other option is this Q&A. And what's nice about this feature is it collates all the questions into one, and I can either dismiss them or mark them as answered. So it's easier for me to track the questions as they're coming in and manage them instead of this big long dialogue happening. Then I'm trying to, it gets too confusing to try to manage questions in the chat. We can ask folks to use the Q&A feature. Ultimately, someone's not paying attention and uses the wrong thing, but if we can try to corral them into Q&A, it's much easier.
Okay.
I can try. I wonder if I can disable the chat for folks.
Yeah, well, it says all panelists, so the attendees should not have access to it.
Not to this conversation, they do not, but they could start their own chat with us if they wanted to. That's what I want to discourage.
Yeah, no, we don't want that.
Please send us your questions via Q&A.
All right, so that's what we want. We don't want them to use anything else. So if I screen share with you for a moment, here's what I've put.
Shoot.
Sorry, I have to choose screen share. Dang.
Hello, folks. We're just going to wait a few more minutes and let folks get in the room, and we'll be started shortly.
How many are we expecting, John?
About 35 signed up, and we're currently at 22.
Okay.
So that's about right. Would you like to get started?
Yeah, go ahead and start with the intro, and then we'll move on in.
All right. Well, hello, everyone. Thank you for joining us today for ACP's webinar, Setting the Stage, a look at the places and circumstances in which these trainings can apply. This is the first of a 4-part webinar series. They'll each take place the same time for the next 3 Thursdays. Today's speakers are Dr. Claire Bamberg in Vermont and Dawn Starry in California. And I will turn it over to you two now.
Thank you, John.
I want to start off by welcoming everyone and to let you know if you have questions during this time to go ahead and there are two ways you can get a hold of us. One is to use Janelle Moore's email. So that's a long-term thing. You can do this in between any of the sessions that we have. And the other is if you want to ask any questions immediately today, to go ahead and use the Q&A feature, which looks like this, but is probably located at the bottom of your screen. Go ahead and put those questions in. We're saving the last 10 to 15 minutes to go ahead and answer those questions. And we want to welcome you again today. Go ahead, Dawn.
Thank you. Hello, everybody. My name is Dawn Starry. I'm a pastoral counselor. I have a master's in pastoral care and counseling from the University of San Diego. I have been working with trauma survivors, primarily refugees and asylum seekers, for the past 10 years. So in that work, it's overwhelmingly due to the traumas around forced migration as well as torture in their home country. But in that work, it more than one time has come out around domestic violence and the issue of as families acculturate and move into the United States, and the experience of the stress that often will result in domestic violence. So I will be speaking about that next week, and I'll go into more detail about that in a little bit. But that's what's brought me here, is that work that I've been doing for these past 10 years with trauma survivors in San Diego. So Claire, I'll pass it over to you now.
Okay. Hi, I'm Claire Bamberg, coming to you from Vermont. I have been an ordained minister in the UCC now for 37 years. I did my CPE training at the Brigham and Women's Hospital and was on also on call to Children's Hospital. It was long enough ago so they didn't have their own chaplain. I'm a licensed mental health professional in 3 states and a certified mediator and a professional certified coach. My experience around attending to matters of grief in people's lives have come to me ever since my very first CPE experience. And in fact, before that, when I was trained as a hospice chaplain before I ever went to seminary. I've had personal grief, there's systemic grief, there's grief at the loss of a limb or a job or location, all of which we're going to talk about on the 3rd week, which is the week in which I'll be presenting exclusively. So just to get the pattern down, today we're going to set the stage, talk a little bit about what we're going to do. Next week, Dawn will be presenting on her topics. The 3rd week, I'll be presenting exclusively. And then the 4th week, we're going to do a kind of commonalities and differences, a review, a debrief, and then take specific questions. So again, I want to remind people how to get the questions to us, is to go ahead and either reach us through Janelle over a long term. So we'll have those questions that 4th week. Or if you have immediate questions, to go ahead and use the Q&A feature on your box, the bottom of your toolbar, or it may show up at the top as mine does right here. Okay, Dawn?
Okay, so let me share with all of you. So next week, as Claire said, I will be presenting, and I'm just going to pull up for you my objectives. I just need a minute. They were there, and now I am not finding them. So let me pull that up. But as I pull that up, I will share that what I have been, like I said, I've been focusing on work with trauma survivors, primarily refugees and asylum seekers, but we all have in some way or another endured trauma. And so as we're entering into our work, sometimes things will come up for people that maybe we weren't expecting. So I'll give an example as I pull this up, that, I will enter into a room to work with a client, and I'm thinking I'm entering into that space to talk to them about, that they had witnessed the death of a loved one in their home country. And then as they talk, they begin to share about their own experience of domestic violence, either in their home country or here in the United States. And so it's preparing myself, or I've been trained to sort of enter into that space without like a sense of shock, or to have a look on my face that seems as if I don't know what to do because this thing came from someplace else. So that's part of what my work will be with you guys next week. It's to talk about how to enter into a space with somebody with respect and dignity, even if they're giving us what we would perceive as, as a curveball. So I think, let me see here. And I apologize, this is my first time presenting on Zoom with sharing. So thank you for some understanding and grace as I do that. So next week, I will be specifically, talking about domestic violence, intimate partner violence, and trauma. And the objectives that I will cover, and I hope you walk away with, is to be able to define the difference between domestic violence and intimate partner violence. I think domestic violence is a term that we perhaps hear more often, but intimate partner violence is one that has begun to be used, and they are slightly different, though they overlap. We're going to be talking about being able to understand and be able to access resources about the nature of trauma, language related to trauma, and different types of trauma. So whether it's a one-time incident that somebody had gone through, or if it's a more complex incident, maybe over multiple years, there could be different ways that manifests in a person. And then for the third objective is to talk about that trauma does appear differently in different people. And so what might kind of dispelling the myth of like what may or may not be kind of seen as normal, quote unquote normal. Some people are stoic, some people cry, some people, freeze up. So we'll talk more about that in depth. And then the final objective is to learn ways to respond effectively to the realization that a person you're working with, like I said, maybe they enter in one capacity. For the educators, perhaps you're educating a potential chaplain, and then something is triggered in that person, and there's a flooding of memories around their own experience of domestic violence or intimate partner violence, and you're faced with that. So then how to respond to that in a way that is respectful, in a way that does not re-traumatize, understanding what language to use, kind of how to approach it. And then we'll talk about touch too, because I have, my sense is, and a lot of the work that I do is with interpreters, because I have people from all over the world. And so it seems like a natural inclination as somebody starts sharing a very difficult story to just reach out and touch that person. But that may not be the best way to handle it. That may actually be more upsetting for the person. So we'll talk about that a little bit more in the session next week. And I mentioned that about the interpreters because they're not trained necessarily with trauma-informed care and the way that I am. So I want to share that with you as well around trauma-informed care and how we respond to trauma survivors. So that's a little bit about the objective. And then here are some initial resources. I'll have this for you next week as well as some additional resources. But the first one is this website of womenshealth.gov. And it talks about the difference between domestic violence and intimate partner violence, as well as gives some ideas around next steps, which I thought was helpful. But again, we'll go into that together. And then two books that I have found very helpful in my work is the book, The Body Keeps the Score, and by Bessel van der Kolk, some of you may have heard of. And the other is Trauma and Recovery, The Aftermath of Violence by Dr. Judith Herman. And both of those have been very helpful for me in just sort of understanding the concepts of trauma, how it manifests in a person's body, how to respond to it as a person witnessing it, and just the different types of trauma too. So I wanted to offer those as some resources that, again, I will be able to get to you, and I will have for you next week too, with some additional resources also. So that's a little bit about what I will be discussing next week in depth. And at that time, I'll take questions and answers. And again, as Claire mentioned, if you have any questions, please do send them our way, and then I can be thinking about those before my session next week too. So Claire, I'm going to pass it off to you. That's what I'm talking about. For now, if there's anything that comes up, I'll go in more depth if people have questions.
Great, thank you. I want to remind people that there are two opportunities, or two types of opportunities, to get your questions to us. One is kind of long-term, as Dawn recognized. If you want a specific question answered by one of us, go ahead and do that through Janelle, particularly if you get off the line today and think, oh man, I wish I'd brought that up. And the second is to go ahead and use your Q&A box today. And John will be curating those questions and getting them to us in the last few minutes of our time together. Thank you, Dawn. I can't wait to attend your workshop because I totally am going to be learning things. So Dawn and I have two similar resources. So I want to say that to you to begin with. So The Body Speaks, Bessel van der Kolk, and Judith Herman's book on trauma and recovery apply in both circumstances, particularly when you're dealing with people who have sudden loss or a violent loss. For example, and not to traumatize any of us, my mother told the story of a friend of hers who was on the phone with his daughter during one of the sudden storms we had in Connecticut this winter. She got out of her car, and unfortunately another car jumped the median and hit her, and her father heard this while he was on the phone with her. So, there's anticipatory grief when we have the luxury of seeing a loss coming, and there's this kind of sudden violent wrenching that can take place. And this can come with a sudden loss of a job, the sudden loss of a limb, the loss of a location, any numbers of losses. So I want to talk with you about this just a little bit and let you know what we'll be covering in our time together. And I'm going to share this with you. So these are some of the objectives that I'd like to cover with you. I want to be sure that you understand, as I just outlined a few of them, the circumstances under which or in which grief occurs. We tend to think of it specifically as the loss of a human relationship, or sometimes it'll extend to a pet. And there are many other ways in which grief occurs in people's lives, and I want to talk about that with you a bit. The sole point of our doing this is to lessen your anxiety, so that when you are confronted, not if, but when you are confronted with somebody you didn't see coming. For instance, when I was doing this workshop at the ACPE conference in Scottsdale this last week, there were a number of supervisors in the room who suddenly realized they don't do assessments for students to see kind of where they are in their own grief cycle or grief experience before they actually enter the room with someone. And you run two risks there. One is the risk to the student. The other is the risk to the patient in terms of the student having their own reaction in the room. So I want to talk with you about that in an effort to lessen your anxiety. The third is to identify the resources, human and printed, so local and global, for the clinician and the client. And I'll be going into that in just a moment. I want to identify the different ways in which grief manifests itself with attention to age, developmental stage, the resources they have available to them, their position in the family, and the circumstances of the loss. And fifth is to equip you with the tools to manage even the most unexpected of grief presentations, but also to feel comfort with kind of ones you see coming. Because if you have those tools, you're going to be able to manage your anxiety. This isn't working. There we go. So the resources that I want to bring to your attention that are immediately available to you are your local hospice support groups. And many hospices have a library, a lending library. So there'll be material available for you there. The other one is a resource by Elizabeth Kubler-Ross and Dr. Byock on death and dying with a specific focus on what the dying have to teach doctors, nurses, clergy, and their own families. And the third one that I have listed here is a must-have for anybody who's in this field. And that is, I would suggest that you get a supply of a book called Water Bugs and Dragonflies. When I was full-time in parish ministry, I would give this to every single family that has sustained a loss. It's a lovely opportunity to help people think in terms of what occurs at the time of death. And that's all I'll say about it right now. And then in our time together, we'll be going through this grief cycle. Very, very briefly done for you in this moment. We move from the moment of loss through a time of, and this will be changed by the time we go through it, to re-entry. There'll be some other changes I'll be making in this based on my research. So we'll go through this. I'll help you understand what it means and how to think about it in terms of our time together, and also what it can mean for you as a clinician going to work with people as you are entering. For those of you who are psychotherapists, you're entering your counseling office. For those of you who are chaplains, when you enter a hospital room or a nursing home or a clinical spot and suddenly find yourselves confronted with this. And finally, for the supervisors who may be on the line, to help you work with your students, as Dawn mentioned, who may get flooded or triggered by the very work they're doing. So I'm going to turn this off for now and take a moment and see, John, do we have any questions right now that might be good for us to answer?
We don't have any questions as of yet.
Okay. So what we anticipate in our time together, Dawn and I will be attending each other's workshops and presentations, is that you're going to find some commonalities. You're going to find that some of the tools that you'll be gaining in one place or another actually do apply in both, and that you'll be acquiring essential tools for you to manage your own presence and to be able to be more attentive, because you won't be worried, to the people with whom you're sitting. So I'm going to pause. I'm a didactic presenter. It really helps me to have some questions to which I can respond. So we'll see if we have any. How about you, Dawn? Did you think of anything? I did with you.
Well, yes, as you were talking, I was thinking, it can be off-putting. I'm thinking about my own experience, so like I said, entering into, and so I work both in an office where I see clients. I have literally seen people in parks. I've seen them at their homes. So sometimes the space can feel kind of not always the most relaxing, and then somebody will present with something that I'm surprised by, that like I said, I didn't see coming. And so I think it's important that you point out, Claire, and that we'll talk about this next week too, is the sense of managing our own anxiety and being able to recognize in ourselves well enough when something might be triggered. And so instead of kind of going into that panic mode, being able to take deep breaths, being able to sort of be present in that moment and pull out your own resources so that you can be available to that person as they're presenting with something that you're not expecting. So that's when I was listening to you talk, Claire, that came up for me, and that's such an important part of it too, because if somebody else, even if it's not what they're talking about that triggers you, even if it's just their own anxiety or their own stress that might kind of put you in that panic state, to be able to recognize that in yourself and then to manage that too, so you can be present to that person, I think is critical.
So the other thing that came up for me, and I don't know if you're prepared to go into this now, but I would love it if you did, is to talk a little bit about the difference between domestic violence and intimate partner violence. Can you do that for a moment?
I can talk about it a little bit. I'll go more extensively next time. But I think really sort of the briefest definition of that would be that, so intimate partner violence is, my understanding, is that that's really reserved for, say, for example, a husband and wife, or, you know, an intimate couple, two men in a relationship, a man and a woman, etc. And so and then domestic violence could be anybody who is, so like a child in a home that witnesses violence. And so that could be domestic violence. So that it's kind of a broader, it's a broader umbrella, though those terms, I've noticed, seem to be used interchangeably, but one seems broader than the other. And then with intimate partner violence, I am also on a committee in my diocese. I'm in the Episcopal Diocese in San Diego, and I'm on a committee that's doing work around how to respond to survivors of clergy sexual misconduct. And so in that work, as I was reading about that last night and preparing for this, coming up that an intimate partner or even in domestic violence can be somebody who maybe is not like the mother or father, but is somebody who sort of has that role of a guardian or of a parent, or like a clergy member who seems sort of like an extended part of the family. And that if there's a violence or a violation there too, that could be put into that definition of intimate partner or even domestic violence, if that makes sense. I hope that was clear. But that it's not black and white. It's not a home with mom and dad. It could be extended family. Yes, hopefully that makes sense, that I can clarify it a bit more. But just that violation of boundaries. And it's important to say that domestic violence or intimate partner violence can, of course, be physical violence. It could be sexual in nature. It could be, battery, but it also can be psychological and emotional harm done. So isolating a person, stalking a person, sending harassing messages, posting about them online in a way that is either violating their privacy or is smearing their reputation, so that it's all encompassing. It's not just, because I think when I was growing up and I would hear about this sort of concept, I often thought that just meant somebody was, that it was just limited to being hit. And though we know too that if somebody's hitting somebody, that often is, if not exclusively, includes, the verbal and emotional abuse too.
When I was an expert witness in 2 counties in Indiana, one of the things we learned quickly was what judges understood emotional and physical, or emotional and verbal violence, and which ones didn't count that if there were no bruises or broken bones. So yeah, important. So somebody's asked, are you going to cover specific interventions that are helpful when encountering someone having a trauma or acute grief response? So I'll answer for my part, yes. That's one of the things that I think is going to be the most important for you as clinicians in terms of lessening your own anxiety, is to know what to do and what not to do in those initial moments and throughout your work with them. And I see Dawn's head going up and down. You want to respond, Dawn?
Yes, I agree. I echo that I will be talking about that as well. What to do and what not to do, especially to not re-traumatize or to worsen the trauma that's presenting the person. So yes, talking about that specifically as well, to give you some tools and resources that you can access in those moments.
And if you have specific questions about, do I do this, or what happens if that, then go ahead and get those to Janelle or get them on the Q&A now. Okay, so for example, we're being asked in the ED or in the ground after an event. So I work a lot with first responders. And the people that I get the most calls from for this training happen to be EMTs and the fire department. You've got a small child who's sobbing on the sidewalk and their parent is not going to be coming to comfort them because they were in the home and couldn't get out. What do you say? What do you do? How do you be attentive to that child in that moment? And I'll even talk about the difference in developmental stages. So what you say to a 3-year-old is completely different than what you would say to an 11-year-old. And then in the ED, yes, absolutely, same thing. So this is where, I'm just going to say this to all of you who are on here, and you can spread this to your colleagues. This is where it would be really helpful if you got a case to Janelle. Like, give her a case example that she can forward to us, and let me specifically respond to walking you through what you do and do not do in those moments and the questions to ask so that you can know that your responses are appropriate. How about you, Dawn? ED, or you're in the park, or you're in the hospital room. What do you do when that comes up? Will you be answering that?
Well, I will address both, because I have had the experience where I will be in a session. I can remember this still. We're walking down the street. It's myself, a client, and an interpreter, and it comes out that there had been an incident the day before about the husband. My client was the wife in the situation, and the husband had attacked her in front of their children. So I will be able to talk to sort of how do you handle a situation that is somebody is in the middle of and is ongoing, is emerging, exactly. And then I have had the experience of where like I'm thinking of an example right now of a client that had an abusive relationship in the past, but has not processed that. And so it still comes up for her, but it's not, she's safe. She's out of the situation. She's actually divorced that person, but she still has the residual effects. So yes, I can talk to both a situation that is emerging and that somebody is in, and resources for that, which would be different than if for somebody who is out of the situation and who is safe, but still needs support, but the responses would be different. So I will be able to talk to both of those.
Okay.
About both of those.
So folks, questions now and questions through Janelle will help us be sure to get you exactly what you're looking for. As Dawn alluded to, if we have some advance notice, that's great. But even questions right in this moment, we can go ahead and move into that right now. If there are some things you're dealing with right now and you want to know, okay, I'm going into this hospital room or into this counseling room this coming week, how do I, then go ahead and do that right now. As I said, there are differences in positions in families when you come to loss. Was it the breadwinner? Was it somebody who now is left and doesn't know where any of the records are? Was it a sudden loss of a spouse? That's different than losing a parent, and it's way different than losing a child. I mean, all these things are things to take a look at, as well as the circumstances under which the loss occurs. I actually had somebody today that I was working with who has just voluntarily and excitedly switched jobs within the same company, and she's kind of like, what is this sadness that I'm feeling? And I'm angry. It's like, well, those are part of the grief cycle, completely understandable. And even being able to reassure people that, yep, that's the way this is. You're not abnormal or managing anything unusual to grief. It may be unusual to you. Let's help you figure out what you're feeling and where to go with that. So, yeah, go ahead, Dawn. You were going to say something?
Well, I was going to add, too, the point you made clear about, like, it can be very beneficial to hear someone with a specific case, right? So to bring a case study, even if it's something in the past that maybe you would like to get someone's input or feedback on, it can be helpful for all of us to hear. So if somebody sends in that information for either my session next week or for yours, Claire.
All right, we'll both get it. Yeah.
Okay. But yeah, so I think that can be very helpful to be able to give feedback on that, because I mean, I've been doing this a long time, but I still sit, right, and think, gosh, could I have responded to that differently? It's important to be able to process that, and that can inform everybody's work, not just the work of the person who sent that in.
Well, there are two aspects to that, right? When we've been doing it so long. One is we have been doing it so long that we don't realize something of what we do is remarkable, which is what the questions help lift out. And the other is that we're continually honing our skills and doing the research that might improve the ways in which we're present.
Right.
So what we're intending to give the people who attend these webinars are like the current, our current best practices. Somebody else wrote in and said, I was interested in knowing more about some of the red flags, what they are for unprocessed grief when I'm interviewing CPE students for our residency and internships. So there are a couple of ways of approaching this. One is fairly direct, to be able to say to the student, you're going to be running into a number of different clinical situations here. There's a couple of questions to ask, like what's your experience with loss, sudden loss? What have you done to take care of yourself around that? Do you know what the resources are that are available to you should something get triggered? And then what you're watching for is denial, a kind of a, I don't know, in legal work, we call it the 1,000-mile stare, where people are suddenly not behind their eyes. They've gone somewhere deep inside. You can even ask them in a way of figuring out what is their tolerance level, what level of resourcing do they have, what level of personal work have they done. Ask them to talk with you about how they've managed that. You can do that for a number of circumstances, but certainly for this, where most assuredly when they're in the clinical setting, particularly in a hospital, they're going to be running into this. And again, as much as you care for them, you also need to care for the patient. So this is one of those places where you don't want them to unfortunately learn about themselves that they haven't adequately processed this when they're in the room with somebody whose story mirrors their own and they are re-traumatized. Is that helpful? The person that asked that question, did you get what you needed there? You can just write in real quick to John, that'd be great. And any other questions?
And did you see, Claire, that came up, a case about in labor and delivery?
No. Wait a minute, let me get to it.
One just came in.
Okay. So the last question, the person said, thank you. Yes, you answered my question.
Okay.
And then we do have a specific case that somebody typed in about labor and delivery. Probably easier for you two to read it and respond.
Okay, let me read it out loud. Actually, there are a couple of them that have come in. Wow. Okay. So let me read this one out loud. So the patient's fiance was angry with staff. Oops. So what happens is these jump. Patient arrived in labor and delivery at 22 plus 6 and held at 5 centimeters dilated for 5 days. Wow. On the 6th day in the hospital, staff was not able to find a fetal heartbeat. It was determined that the patient was experiencing a fetal demise. Patient is Christian and very religious. I'm losing the rest of the question. The the staff informed chaplain that the patient's fiance was angry with the staff about how this could have happened under our care. Patient was not angry, processing the event. Okay, so let me stop right there and let's speak to the how differently the actually pregnant person is experiencing grief compared to the partner. So let's just pay attention to that for a moment. So the person who is carrying the child begins to develop a relationship with that child the moment they realize they're pregnant, and certainly at the first point of any kind of movement that is detected. When that patient loses a child, either through fetal demise or stillbirth or immediately after, they're losing a direct relationship that changes their experience of grief from the one that their partner is experiencing. they experience the grief of a hoped for or promised, that's very important, that word, a promised relationship. And so the couple needs to be helped to manage this in very different ways. Of course, the patient was at a different place than the patient's partner. And this would be important for you to know how to manage that, how to address that. The patient then, this is so hard, had to be induced and give birth. So best practices for navigating this situation. The staff probably knew to coach the partner to stay present as a birth coach, even though the outcome was going to be different. In this case, there are going to be a number of people who need attention: the patient herself, the partner, and the staff. This is something that leaves staff also traumatized. So you would respond to them all very differently. When I've dealt with this with staff in hospital settings, I've always gotten the staff together in a group afterwards to kind of debrief. Usually the nurse managers will make time for that because they want retention. This is a really good recipe for burnout. And then what I would hope is that you would be working on a staff of more than one, and one person could sit with the mother, and one person help the dad or the partner through whatever experience they're having, not to exclude the other, but because they'll need very different attention. And this is a recipe for so many partnership breakups, because people experience the grief so differently and they don't understand why the other one isn't where they are. So I'm going to stop there. If there's more, I'm going to ask you to write in, give me more specifics. I will also respond directly. If Janelle and Dawn and I decide that this is one where somebody needs a direct response, I will make myself available. Okay, next question. I have a patient currently who's grieving the loss of her son to cancer 2 years ago. She's become an alcoholic in the wake of his death, and she doesn't seem to have a lot of support. There's your key right there. We'll talk about that in a moment. During our time together, she showed me a video of him. Any ideas about how to process in terms of helping her process her grief and probably seek out other copings? Yes. So the first thing to do is for you to understand where she is caught in the grief cycle. The second thing is to help her explore what other resources are available to her other than you. Who knew him? Who might be somebody she could talk with him about? How would she celebrate his life? What are the dreams she had for him? Getting her talking out of her experience of him alive, so that she can begin to take a look at who she was before and who she can be now. Is there any places in which she can dedicate her life? Is there a grief support group she can join? 2 years is past the longest part of a healthy grief cycle. And so, we want to help her move a degree or two into really managing this well. If she knows she's an alcoholic, a very appropriate suggestion would be also to ask her if she would consider joining an AA group specifically to deal with her alcoholism as apart from her grief, because the one now will complicate the other. You're really dealing with a dual diagnosis at this point. And again, more. If you need more than what I just gave you, please write in. I will directly address that. Another question, will you also be addressing recognizing resilience to avoid over-treating or over-addressing perceived crisis to maintain the client or patient's self-agency? Absolutely. Our goal is not to disempower people, right? It's to give them the information, the skills, the resources to really feel a sense of being empowered around their personal agency. People always enter a relationship, a chaplaincy or a pastoral counseling relationship at that point. So yes, absolutely, to judge where or how you might add to or support and where to empower and resource. You were going to say something, Dawn.
No, not about that.
Okay.
I was just agreeing with you that
Okay.
what I will add. What I was nodding to agree that, yes, it's about empowering people, because trauma takes away a sense of control. Trauma can take away a sense of being able to manage one's life. And so, yes, that piece of really looking at their resiliency and engaging with them around their self-agency is so key in that. That's why I was nodding.
Okay, good. So here's one for you. Well, it's for both of us, but for you. As a chaplain in a level 1 trauma center, I visited a patient in the middle of the night who was inconsolably sobbing. Her husband had beaten her with a crowbar, breaking her arms and legs. She was bruised everywhere, and her nurse called asking for help. The visit began with the patient sharing that she was fearful for her 6-year-old daughter who was staying with her husband's mother, and she was afraid her abuser, husband, would be in contact with their daughter even though there was a restraining order in place. You want to take this one?
Okay. I will do my best to answer this one, yes. So, and again, I'll echo what Claire said. If I don't answer this fully, please do follow up and let me know what you would like more information about. So, in this, and I guess I have questions too, like if she had a restraining order that he had violated, and that's when he had broken her arms and legs.
Mm-hmm.
Right, because that would make it especially understandable that she was afraid that he would maybe break it again. So it seems certainly in that moment like being present and trying to bring some calm and peace to that, like helping her regain her own sense of calm is important. And so that you could, well, see, now this is a question that I need to ask, because I know there might be a difference between how a chaplain would respond and how I would, but as a counselor, because I would want to get some additional information, and maybe you still get some additional information to sort of see if the situation is secure, and then you can call perhaps your advisor, or if there's somebody in the hospital that you're supposed to contact to sort of figure out next best steps.
Right. So there sorry, go ahead.
Go ahead. No, go ahead.
I was going to say the bottom line is, for everyone on this call, you are a mandated reporter.
Right.
So the fact that there is some reason to suspect that a child is being neglected or abused, you don't get to make that judgment. You instantly need to report this to whatever Child Protective Services is in that area. So again, that's not a clinical response. It is, however, a legal mandate, and I just want to lift that up. And
okay,
it may be offer some reassurance to the mom. That will mean getting some data. It may be that you notify a social worker in the hospital and they take it from there. But that whether you articulate that or not in the moment of consoling her, that is an absolute requirement. Okay, sorry, Dawn, go ahead.
No, that's important to say, and thank you. That helps me understand that too, because that's what I was trying, because that's, those are the steps I would have to take. So you can gather information in a way that is still like just understanding that as you're sitting with this person and trying to console them and sort of bring some peace so they can, stop sobbing and feel a little more sense of control, that you can ask those questions in a way that are not intrusive, right? Like just asking was there a restraining order for you? I understand, and then just validating, like, I understand your concerns, and then explaining that you do have to share this, and then and she sounds like she would want this shared anyway. Sometimes people feel fearful, that if I share, what will happen to my family, what will happen to the child. But in this particular case, she's very fearful that something will happen. So then to explain next steps, even saying that you're going to talk to the social worker, that you have to share for the safety of the daughter, and that then once it's reported,
yeah,
right, exactly, getting that information out, and then once it's reported to for the protection of the child, and that will probably reduce a lot of her fear. And and just knowing that her child is going to be watched out for, and that authorities will go out to ensure her safety, the child's safety, will probably reduce the woman's fear a great amount. And so then you can begin to even work with her. And this is obviously I know chaplains wouldn't be in the long hall necessarily. You'd be in the room there, and then maybe you maybe see them one more time, or you don't see them again. But it would seem to me that then the work of the social workers to come in and then to try to get this family into services, because she maybe isn't ready to see the work that she has to do. She's focusing on her child's safety for obvious reasons, but then being able to do her own work will be important. So getting those other resources that are available to contact this patient as well, I think is important.
One of the things that we're working on in the leadership between AAPC, or the former AAPC, and ACPE, is to begin to think in terms of discharge planning with pastoral counselors who may be in the area. So chaplains in hospitals can make trusted referrals for aftercare. So I'm just flagging that. So here's another question. And we have a couple more at this point. I've worked with a chaplain resident who melted, cried with folks, and had elicited care from the family person who is grieving. His reaction was so large. When attending a death, particularly a fetal demise, the chaplain was in therapy. What types of strategies might we have utilized to assist this chaplain resident to navigate death situations? The grief overwhelmed him. He entered situations as if he was the one experiencing loss, not the one, not the one accompanying the person in grief. So this is exactly what I was talking about earlier. This is what we absolutely want to avoid for everyone in this picture. So to begin, what I am willing to do is to work with the chaplain educators on a level of developing an assessment formula, questions you can ask, and then to know what resources would be available. Though he was in therapy, it sounds like he had an unresolved something. Perhaps he was a twin and his twin died. Perhaps he had a younger sibling who died, perhaps an older sibling. Maybe he lost a child of his own. Again, you heard me say earlier that it's often the mother, that is the birth mother, the birthing mother, who gets attention. The spouse, the partner, doesn't often get the opportunity to metabolize or work through the grief. So a simple question for your incoming students or people who are applying to CPE might be, tell me a little bit about your grief history, and how have you managed it, and when have you encountered it? How do you understand it? If you were in a sudden circumstance, what would your response be? I, as a supervisor and caring for patients, it sounds like this happened to him more than once. I would probably stop him from visiting anyone that I suspected, particularly in cases of fetal demise, until he had done some very specific work in that area, because he's re-traumatizing everyone in the room and adding to the sense of loss in that moment inappropriately, to understate the obvious. So again, more questions, write to Janelle. I will help you figure out how to ask those questions. Okay, so this is a follow-up. For the fetal demise case, could you speak to directly how to care for the patient, mother of the baby, especially understanding that her emotional pain is exacerbating her physical pain? Yeah, in other words, there was no longer pain for a purpose. Additionally, do you have any resources, stats, or research that could help make the case for staff debriefing? We have a clinical manager. Okay, so yeah, the Mayo Clinic has done a tremendous piece of research on death by suicide in the medical community at this point in time because of the lack of self-care that is coming out. So last year alone, 400 physicians died by suicide. That's equivalent to a small medical school. So beginning to take a look at the research, it's out there. I'd start with the Mayo Clinic, go to the Cleveland Clinic, The AMA is meeting in Charlotte, North Carolina in September. The whole conference is on self-care because of the epidemic of suicidality in our caring professions, in our medical professions. So I can direct you to that. I can also, I'll direct you to that. In terms of addressing the mom, if the partner is lost in their own place, it sounded like they were very angry. This is one of those cases where, you'd want a midwife or a doula, somebody who could be there specifically for her. I actually am working with a student now who is going specifically into the area of training to be a first responder in circumstances of fetal demise, believe it or not. And she's working with the doula agency out of Boston. So you're right. They would need very different kinds of care. And I'm not sure I'm answering your question all the way. She'd need special attention. She would need to be encouraged to hold that baby, to give herself a sense of closure. The staff would need to leave the room and give her some time, or at least she would need to have that option. Perhaps the couple together, or encouraging her to just have some closure with that child. That would be especially important. So I'm just going to stop answering specifically there. Because I think I've given you some things to go with. And if you have more questions, please write Janelle. We only have 8 minutes. Yeah, go ahead.
Can I just interject really quick, Claire, about the piece about self-care?
Yeah.
I was talking to a clinician who worked in a particularly difficult situation. So she was hearing difficult things as the clinician, but then staff who would maybe manage the paperwork, and have to was reading some of the stories, the staff would then go to the clinicians to manage their anxiety. So then the clinicians were sort of getting both pieces, right? So this piece around self-care, not only for the immediate provider, but then for all the members of the staff, it's so important. And I think, because in the work that I do with refugees, the admin are still interfacing in some ways, right? Or even if they're reading the stories, but they often are not thought about, I think. So it's just that piece around really doing the work for the support for the whole staff around self-care is so vital. So I just wanted to put that in there.
I was blessed in that when I was doing the chaplaincy rotations at the Brigham, and I did 4.5 units there, so I had time to get really well known. The ICU nurses got to the point where they knew when they had a difficult death, they could call, and the nurse manager there set some time aside, and I would go in and work with them. And it was invaluable. I only say that because they called upon it, that it was of that kind of value to them. I think I can state that. Okay, let me... So this last question that we have for now, and we are going to have to close with this one. An 18-month-old drowns in his vomit in the wee hours in the morning. Efforts to revive him in the ED are not successful. The patient's mother is in acute grief, crying, screaming. The 4-year-old sister is in the hallway and does not know her brother is dead. Suggestions for immediate response to the mother and then for the sibling. So again, this is where it's really helpful to have a two-person team at least. I would strongly suggest that somebody go be with the child. A 4-year-old needs to ask very specific questions, and they need very specific answers. So they are not into abstract thinking. It's very concrete. She needs to know why mommy is crying. She needs to know that somebody is helping mommy. She needs to know that in a minute mommy will come be with her, or in some time. And then basically she needs to be distracted. Excuse me. It's her mother who should give her the information. And then both people need to be attendant to both the mom and the daughter. Meanwhile, another person is in the room with the mother and sitting with her. In many cultures, having another woman there would be important, but it's not indispensable in our culture. To be able to witness to and literally support the grieving. And and again, this would be one where follow-up with staff is going to be absolutely imperative. These are some of the worst situations. I will, again, just briefly, a personal story, got called over to children, teen parents, and their infant had died a SIDS death. And the things they needed to know were they were Catholic. They needed to know their child was going to be safe wherever they had gone. They wanted the child baptized. And for those of you that are gasping, I did do that. My attention at that point was for those parents. It was not about whatever theology I might have to consult. So you have some decisions that you need to make in the moment. And for me, as I think is true for many of us, they're driven by the needs of the patients that you're addressing. So again, an 18-month-old, you've got a mom and a sibling, you separate them, you have 2 people available, appropriate responses and interventions, and then bring them back together to work that out. Okay, so I think, sorry, go ahead, Dawn.
Oh, no, I didn't say anything.
So I think our time is up for now. I do want you to know that this is an example of the kind of thing both you can present in terms of questions and that you can expect in terms of response. Dawn and I will be informing each other as we work along. And again, in that last session, that 4th week, we're going to do some of the similarities and differences of the things we've learned along the way. I want to thank you so much for being here with us today. John, do you have anything you want to say in closing?
Thank you both for participating with us today. Thank you everyone who attended. Just a reminder that this is the first part of a 4-part series. It'll be the next 3 Thursdays, same time, same place. Although if you haven't registered yet, please go to the ACP website and get registered for one of the upcoming sessions. Thank you very much.
Take care, everybody.
Thank you.
Bye.
Thank you.
Bye-bye.